What is the number one medicine that neurologists and pain specialists prescribe more than almost anything else for nerve conditions in seniors across America? A medicine that genuinely helps millions of people manage their nerve pain every single day. But also a medicine, actually two specific medicines, that carry side effects in adults over 60 that are so serious, so underreported, and so completely different from what most patients are ever told at their appointment, that leading neurologists in both America and Japan are now openly questioning whether these medicines are being recommended too freely to a population whose bodies respond to them very differently than younger patients. Today I am revealing everything about these two nerve medicines, the names, the benefits, the mechanisms, and the shocking side effects that every senior taking them absolutely must know about right now. Stay with me completely because every single piece of this information matters. And real quick, right now, before we go any further, if you have a parent, a grandparent, a spouse, or anyone over 60 who is currently taking medicine for nerve pain, pause this video and send it to them immediately, because what we are about to share could protect them from side effects that nobody warned them about. And if you are not subscribed yet, hit that subscribe button right now. Every single week, we bring you honest, research-backed, and genuinely life-changing health information that your doctor probably never had enough appointment time to fully explain. Now let us get completely into this because this information is urgent and every senior deserves to know it. Before we reveal the two medicines, let us spend a moment understanding something that most Americans do not know, but that Japanese neurologists have been discussing openly for over a decade. In Japan, a country with one of the oldest populations in the world and one of the most sophisticated approaches to senior neurological health, doctors approach nerve pain management in adults over 70 with a fundamentally different philosophy than their American counterparts. Japanese neurologists frequently express concern about what they call the polypharmacy problem in elderly nerve pain patients, the tendency to add more and more medicines to manage symptoms without adequately considering the cumulative effects of those medicines on the aging brain, the aging nervous system, and the aging body as a whole. Japanese medical culture places enormous emphasis on understanding the complete pharmacological profile of any medicine before prescribing it to a senior patient, including the long-term effects on cognition, on balance, on mood, and on physical dependence. And it is this Japanese philosophy of complete informed consent that we are going to bring to our discussion of these two nerve medicines today, because every American senior deserves the same complete picture that Japanese neurologists insist their patients receive. The first medicine is duloxetine, sold in America under the brand name Cymbalta. And here is the first thing that shocks most people who hear this. Duloxetine is not primarily a nerve pain medicine. It is an antidepressant. Specifically, it is a serotonin norepinephrine reuptake inhibitor, an SNRI, that was originally developed and FDA approved for the treatment of major depressive disorder. Its use for nerve pain is what is called an off-label and extended label use, meaning doctors prescribe it for nerve pain based on accumulated clinical evidence, but it was not originally designed for that purpose. This matters enormously for seniors, because prescribing an antidepressant for nerve pain means introducing a medicine into the aging body that affects not just the peripheral nerves, but the entire central nervous system, the serotonin pathways of the brain, the norepinephrine pathways, the cardiovascular system, and virtually every organ and system that these neurotransmitters regulate. How does duloxetine help with nerve pain? The mechanism is genuinely interesting. Duloxetine increases the availability of both serotonin and norepinephrine in the synaptic spaces between neurons throughout the central nervous system. In the descending pain inhibitory pathways, the neural circuits that run from the brain down through the spinal cord and modulate how much pain signal reaches conscious awareness, serotonin and norepinephrine are the primary neurotransmitters. By boosting their availability, duloxetine essentially amplifies your brain's own natural pain-suppressing circuits, turning up the volume on your body's internal pain control system. For certain types of nerve pain, particularly diabetic peripheral neuropathy and fibromyalgia, clinical trials have shown that duloxetine produces meaningful reductions in pain intensity in a significant percentage of patients. It is not a cure. It does not repair damaged nerves. But for patients whose natural descending pain inhibition pathways have become less efficient, which is common in chronic nerve pain conditions, it can provide genuine and meaningful symptomatic relief. But here is where the Japanese philosophy of complete informed consent becomes critically important. The side effect profile of duloxetine in adults over 60 is significantly more serious and more impactful than most patients are ever told. The first and most commonly reported side effect in seniors is nausea, often severe enough in the first 2 to 4 weeks to significantly affect food intake and nutritional status. In seniors who may already be managing borderline nutritional deficiencies, this medication-induced nausea can precipitate meaningful declines in overall health. The second major side effect is orthostatic hypotension, a sudden drop in blood pressure when standing up, that is dramatically more common and more dangerous in older adults. When blood pressure drops suddenly upon standing, the immediate consequence is dizziness and lightheadedness. And in seniors with age-related balance difficulties, the consequence of that dizziness is falls. Dangerous, potentially catastrophic falls. A systematic review published in the journal Age and Aging found that SNRI medications including duloxetine were associated with a significantly increased fall risk in adults over 65. With some studies reporting fall rate increases of over 50% in seniors taking these medicines compared to age-matched controls not taking them. The third major side effect of duloxetine in seniors is hyponatremia, dangerously low sodium levels in the blood. SNRI medicines have a well-documented tendency to cause SIADH, syndrome of inappropriate antidiuretic hormone secretion, which causes the body to retain water and dilute the sodium in the bloodstream. In seniors, who are already at higher risk of hyponatremia due to age-related changes in kidney function and fluid regulation, duloxetine-induced hyponatremia can develop rapidly and can present with symptoms including confusion, headache, seizures, and in severe cases, loss of consciousness. A study published in the British Journal of Clinical Pharmacology found that SNRI-associated hyponatremia was significantly more common in patients over 65, and that many cases were initially misdiagnosed as dementia or stroke because the cognitive symptoms of low sodium so closely mimic these conditions. Perhaps the most shocking side effect of duloxetine for most seniors who learn about it is the severity of its discontinuation syndrome. What happens when you try to stop taking it? Unlike some medicines that can be stopped relatively easily with gradual dose reduction, duloxetine discontinuation is notoriously difficult and notoriously unpleasant. The brain becomes physically dependent on the artificially elevated serotonin and norepinephrine levels that the medicine creates, and when those levels drop during discontinuation, the result is a constellation of symptoms that researchers have termed discontinuation syndrome. These symptoms include severe dizziness, electric shock sensations in the brain and body, commonly called brain zaps, severe anxiety, insomnia, extreme irritability, flu-like symptoms, intense emotional lability, and in some patients, profound worsening of pain. A study published in Psychotherapy and Psychosomatics found that duloxetine had one of the highest rates of discontinuation syndrome among all SNRI medicines, with a significant percentage of patients experiencing severe symptoms even when tapering slowly under medical supervision. This is information that every senior starting duloxetine for nerve pain absolutely deserves to hear clearly before taking their first dose. The second medicine is amitriptyline. And this one has an even longer history, an even broader use pattern, and in many ways an even more concerning side effect profile in seniors specifically. Amitriptyline is a tricyclic antidepressant, one of the original antidepressant medicines developed in the 1950s that has been used off-label for nerve pain management for decades. It works through a different mechanism than duloxetine, blocking the reuptake of both serotonin and norepinephrine while also blocking multiple other receptor types including histamine receptors, muscarinic acetylcholine receptors, and alpha-adrenergic receptors. This multi-receptor blocking activity is what makes amitriptyline effective for nerve pain, but it is also what makes it particularly problematic for seniors in ways that Japanese neurologists have been warning about for years. Japanese clinical guidelines for elderly patients explicitly flag amitriptyline as a medicine requiring extreme caution in adults over 65, listing it in what Japanese geriatric medicine calls the inappropriate medicines for elderly patients category alongside several other anticholinergic medicines. The reason is the medicine's powerful anticholinergic effects, the blockade of muscarinic acetylcholine receptors throughout the body and brain, Acetylcholine is one of the most important neurotransmitters for cognitive function, for memory formation, for bladder control, for bowel function, and for cardiovascular regulation. When amitriptyline blocks acetylcholine receptors throughout the aging brain, a brain that is already producing less acetylcholine than a younger brain as part of the natural aging process, and the resulting anticholinergic side effects can be devastating. The anticholinergic side effects of amitriptyline in seniors include severe dry mouth, urinary retention, particularly dangerous in older men with enlarged prostates, constipation that can progress to dangerous bowel obstruction, blurred vision, confusion and delirium, memory impairment, and a profound increase in dementia risk with long-term use. The connection between amitriptyline and dementia risk in seniors is one of the most alarming findings in recent geriatric pharmacology research. A landmark study published in the British medical journal JAMA Internal Medicine, analyzing prescription data from over 58,000 patients, found that long-term use of anticholinergic medicines, including amitriptyline, was associated with a significantly increased risk of dementia, with the risk increasing with cumulative dose and duration of use. The researchers found that patients who had taken amitriptyline for more than 3 months at typical nerve pain doses showed a measurably increased risk of dementia diagnosis in the years following treatment. Beyond the dementia risk, amitriptyline's antihistamine effect makes it profoundly sedating, causing daytime drowsiness and cognitive slowing that significantly impairs seniors' ability to drive, to engage in complex daily activities, and to maintain the mental sharpness that is so critical to independence and quality of life in older adults. Its alpha-adrenergic blocking effect causes orthostatic hypotension, the same dangerous blood pressure drop on standing that we discussed with duloxetine, further increasing fall risk, and its effect on cardiac conduction, slowing the electrical impulses that regulate heart rhythm, makes it potentially dangerous for seniors with any degree of cardiac conduction abnormality, a condition that becomes increasingly common with age. Now I want to stop right here and share a story that brings everything we have been discussing to life in the most real and personal way. Riley is a 71-year-old retired architect from Seattle, Washington, a man of Japanese-American heritage whose family had always maintained strong connections to Japanese cultural approaches to health and medicine. Riley had been experiencing peripheral neuropathy for approximately 2 years, the tingling, numbness, and burning sensations in his feet and hands that had progressively worsened and significantly affected his quality of life. His primary care physician had first prescribed duloxetine for the nerve pain, explaining that it would help with the pain signals from his nerves and mentioning that nausea was a possible initial side effect. What Riley was not told was the fall risk, the hyponatremia risk, or the discontinuation syndrome. He started the medicine and within 3 weeks experienced a significant fall in his bathroom. Getting up from the toilet, his blood pressure dropped, he became dizzy, and he fell backward, fracturing his wrist. He was 71 years old with a fractured wrist from a bathroom fall, something that had never happened to him in his entire life. When he raised the fall with his doctor, the connection to the duloxetine was acknowledged, but the medicine was continued at a lower dose. 3 months later, dissatisfied with the limited pain relief and deeply shaken by his fall experience, Riley's doctor switched him to amitriptyline. Within 2 weeks, Riley's wife noticed something deeply alarming. Her husband, a man who had designed complex architectural structures for 30 years, who remained mentally sharp and intellectually active in retirement, who did the New York Times crossword every morning without assistance, was confused. He was forgetting conversations they had had the same day. He was struggling to find words mid-sentence. He seemed disconnected and foggy in a way that frightened his wife profoundly. She called their son, a physician practicing in Tokyo, who immediately recognized the anticholinergic cognitive effects of amitriptyline in his elderly father. He flew to Seattle within the week, reviewed his father's medications, and worked with Riley's doctor to safely discontinue the amitriptyline under careful medical supervision. Within 3 weeks of completing the taper, Riley's cognitive fog had cleared substantially. His memory returned, his word-finding improved, and his wife told their son, "I thought your father was getting dementia. It was the medicine the entire time." Riley's son, drawing on both his American medical training and his exposure to Japanese geriatric medicine philosophy during his time practicing in Tokyo, worked with his father's primary care physician to develop a comprehensive approach to Riley's neuropathy that emphasized nutritional support, targeted supplementation with benfotiamine and alpha-lipoic acid, physical therapy for balance and nerve stimulation, and dietary modifications, while using the lowest possible medicinal doses for the shortest possible time when pharmacological support was genuinely necessary. Riley's neuropathy remains a challenge, but he manages it today with full cognitive clarity, without fall risk, and with the complete informed understanding of everything he is taking and why. He told his son, "In Japan, they tell you everything before they prescribe. I wish someone had done that for me from the beginning." So what should you do with this information? If you are currently taking duloxetine or amitriptyline for nerve pain, the most important message is this: never stop or reduce these medicines suddenly or on your own. Both medicines require carefully supervised gradual tapering to discontinue safely. Duloxetine because of its discontinuation syndrome, and amitriptyline because of the rebound effects of stopping an anticholinergic medicine abruptly. Always work with your prescribing physician on any changes to your medicine regimen. What you should do is have a complete and honest conversation with your doctor about your experience on these medicines. Tell them about any cognitive changes, any confusion, memory problems, or mental fog that you have noticed since starting the medicine. Tell them about any falls or near falls, any orthostatic dizziness, any urinary difficulties, or any symptoms of hyponatremia. Ask your doctor specifically whether your current nerve pain medicine is on the Beers criteria list, which is the American Geriatric Society's official list of medicines that are potentially inappropriate for adults over 65, because both amitriptyline and certain dosing approaches to other nerve medicines appear on this important clinical reference. Ask whether nutritional approaches, benphotiamine, alpha-lipoic acid, methylcobalamin, have been considered as adjuncts or alternatives. And ask whether the dose you are taking is the lowest effective dose for your specific situation, because in seniors, the principle of start low, go slow should guide every prescribing decision. Japanese geriatric medicine adds one more principle that American seniors deserve to hear: the principle of regular medicine review. In Japan, elderly patients on multiple medicines are encouraged to have comprehensive medicine reviews with their physicians at least every 6 months, systematically evaluating whether each medicine is still necessary, whether it is producing the intended benefit, and whether its side effects are acceptable given the patient's overall health status and quality of life. This systematic review approach catches problems like Riley's cognitive decline early, before they cause lasting damage, and ensures that every medicine an elderly patient takes is genuinely earning its place in their daily regimen. The bottom line is this: duloxetine and amitriptyline are real medicines that provide real benefits for real nerve pain in many patients. But in seniors over 60, whose bodies, brains, and nervous systems respond to these medicines very differently from younger patients, the side effect profile is serious enough that complete, transparent, and ongoing informed consent is not optional. It is essential. Riley's story is not unique. Thousands of seniors across America are experiencing cognitive fog, falls, hyponatremia, and devastating discontinuation symptoms from these medicines without ever connecting their experiences to the pill they take every morning. Now use this knowledge, have the conversation with your doctor, and take control of your nerve health with the complete information you deserve. Now, before you go, drop a comment right now and tell me your age and the city you are watching from, and tell me, are you currently taking any medicine for nerve pain? Have you experienced any of the side effects we discussed today? I want to hear your experience because your story matters deeply to every single person in this community. I read every single comment personally, and if this video gave you information that you genuinely needed, information that could protect you or someone you love, please share it right now. Hit that subscribe button, turn on the notification bell, and I will see you in the next video. Take care of your nerves with complete information, complete awareness, and complete control of your own health. This video is for educational and informational purposes only and does not constitute medical advice, diagnosis, or treatment of any kind. The information presented reflects publicly available research and clinical literature as of 2026. The patient story featuring Riley is for illustrative purposes only. Never stop, reduce, or adjust any prescription medicine suddenly or without direct medical supervision. Both duloxetine and amitriptyline require carefully supervised gradual tapering to discontinue safely. Always consult with your prescribing physician, neurologist, or pharmacist before making any changes to your medicine regimen. The creator of this channel is not a licensed medical professional. No statements in this video have been evaluated or approved by the FDA. Nothing in this video is intended to diagnose, treat, cure, or prevent any disease. Never delay seeking professional medical advice because of content you have watched online. Viewer discretion is advised.